Good morning, everybody, and welcome to this webinar hosted by Health Consumers New South Wales around the single-digit patient record. And today we're going to be reporting back the information that you've shared with us and our members have shared with us about the patient record. Before I start, I would like to just, of course, acknowledge the different traditional lands, waters and communities that people across New South Wales are joining us from. I'm in the Health Consumers New South Wales office on Gadigal land, and I pay my respects to elders past, present and emerging. Extend that respect to the elders of all the different countries that people are meeting from today, and of course, welcome and pay respects to all Aboriginal and Torres Strait Islander people who are joining us today. I'd also like to take some time to recognise the importance of lived and living experience. The experiences of people who live with chronic illness, with disability, are carers who've used healthcare, and experiences of the impact of healthcare and of recovery. These lived and living experiences are powerful and absolutely needed to make healthcare better. And that's really why we're here today, to talk about that. We value and respect your experience. Thank you for sharing your time and knowledge, not just today, but in all the work that you all do to make health services better. Now, today's going to be quite an information-rich session and a lot of me talking, so I'm sorry about that. What we're going to do today is provide people with some high-level feedback of what you, our members, and other health consumers and consumer groups have told us about the single digital patient record. We invite you please to make any comments using the chat function. The question and answer function's been disabled for this webinar. And as I said, this is about giving high-level feedback about what people have told us. We will be providing a written report, a written summary of everything that people have told us. We were hoping that that would be ready by the end of the year. That's not possible. So we're hosting this webinar today to give you that important feedback. And there will be a report with everything I say today, plus more, that you'll all get in early February. And as I said, please remember to use the chat function. So I just wanted to provide people with a high-level summary of what we've done to date. And I will provide also some really quick information about what the single digital patient record is. But we've had a webinar with Dr Teresa Anderson, who is the Executive Director of the SDPR Implementation Authority, on the 5th of November. And Dr. Anderson provided us with information about what the plans are and what New South Wales Health is doing to date. That webinar and Dr. Anderson's slides are available, and I'm just asking Tara if she could please pop that link in the chat for people to have a look at. We held a consultation with members, and I know many of the people on this call were at that consultation on the 19th of November, but we've also had a series of informal and formal conversations with our members in different forums, including the consumer task forces, and I'll come back to the task forces towards the end of the webinar. We've also been talking to our colleagues at the Healthcare Consumers Association of the ACT. They're our equivalent organisation in the ACT, and the ACT for the past couple of years has also been implementing a digital patient record, and they've been providing us with a lot of information and guidance. It's been really useful. And Health Consumers New South Wales is also a member of the Affected Communities Working Group that's looking at SDPR, and that's been convened by ACON, the AIDS Council of New South Wales. So what we've tried to do today is take all of that information and provide some high-level summaries of the key themes that have come out of that. But before we get to that, I want to remind people what we're talking about when we're talking about the single digital patient record, sorry. So this is an electronic medical record, and the plan is that it will bring together all the existing patient information that's held on each of us across different areas of New South Wales Health. So the aim is that this will cover all of New South Wales. It'll bring together information on hospital stays and outpatient engagements. It will include scans and tests that have been made either in hospitals or at New South Wales Pathology, visits to specialists in the public system, and any out-of-hospital care that's been provided by New South Wales Health. At this stage, we don't believe, it's our understanding that the SDPR is not going to include GP records or really any sort of records of services that people have received outside of New South Wales Health. So that includes services from non-government providers, including private hospitals and other NGOs, scans and tests from private providers, or at this stage, anything outside of New South Wales. Now, this is what we currently understand the situation to be, but that could change as more things develop. And for more details on what is in and out, I invite you to please watch the webinar and the recording of the webinar we did with Dr. Anderson. This is a slide from one of Dr. Anderson's slides that summarises why New South Wales Health is doing this. And part of it is they have the hope that this is going to reduce the need for patients and carers and family members to have to recall and repeat all different health informations when they're attending different health facilities. We hear a lot at the moment that people might attend a hospital in one part of the state and then receive a service in another part of the state, or even, a different sort of area within Sydney, say, and information about their visits, scans, tests isn't available to people in different parts of the New South Wales Health. So the hope that this is going to create a more consistent experience, regardless of where people receive their care, and that will hopefully lead to more informed discussions around people's healthcare and the decisions that they make. And so what New South Wales Health is saying is that one of their aims is that they hope this will support consumers to be more involved in our clinical care, improving the consistency and continuity of that care. So this is the rationale of why New South Wales Health is doing this. To create this, they've created the Single Digital Patient Record Implementation Authority, which is a relatively new agency that will support this. And the aim of that agency is that it is responsible for delivery of the program. And this is a quote from the Implementation Authority's website, that patients and people are at the heart of all decisions. So this is something that I think we need to remember, and we need to keep reminding the Implementation Authority about why we need to be involved. Because if patients and people are going to be at the heart of decisions, then we need to also be at the heart of the design and implementation. As I said before, Dr. Anderson is the Chief Executive of the Implementation Authority, and it currently consists of some 57 councils, committees and working groups that are involved in implementing the patient record. There are 5 tranches or 5 steps in the implementation, and the idea is that the first group to come on board will be the Hunter New England Local Health District and Corrective and Justice Health, which will come on board later next year, and that all 5 tranches, and that means all of New South Wales Health, will be using the single digital patient record by 2028. So that is the plan. And so in all of our conversations we've had, what are consumers saying and thinking about SDPR? Well, this will surprise nobody on the call, but there's a variety of opinions and thoughts. Some of what people are saying, there's a lot of variety, and some of the opinions are contradictory. There are some groups who welcome with open arms the idea of sharing, and we're hearing particularly from some various carers groups that they really like the idea that this is going to reduce the need to repeat a lot of information, that people will have access to clinical information, other information that will help the person they're caring for. There's other people who are, and other consumer groups who are much more cautious, particularly consumers and consumer groups who have a lived experience of experiencing stigma in healthcare, are much more cautious about how this is implemented and what it can do. So today I want to provide a high-level summary of all these themes, talk about our work in progress, and remind people that we're working towards a full report early next year. And in summary, I think most people start the conversation by saying, this is a good idea, but, and then they talk about their concerns. So general support for seeing the value, but today we're going to look at some of the concerns that people raised. We asked people at our last consultation what people wanted to see from the single patient record. And in summary, people wanted something that was comprehensive and that ideally included information and was able to share information outside of New South Wales Health with GPs and allied health, and also contained additional information that people could upload. So it might be around treatment plans, allergies, test results from other areas, and other additional information. Obviously that it was secure and private. Some groups were really clear that they wanted the ability to opt out and that this was optional. That the record had some functionality that was useful to consumers, that people could set alerts and reminders, and that people had access and control about what was in, what was out, what was shared and with who. And that it facilitated some two-way communication between consumers, carers and families, and clinicians and people delivering care. The identification of carers and substitute decision makers was also seen as a potential advantage of the system, and so that there was on record information about who was a substitute decision maker for somebody, any additional information such as advanced care directives or other important care plans were there and available for people to use in different settings. And that it was easy to use, that it was intuitive, obviously for consumers, but also for the service providers, that it all made sense and was easy to use, and that there was a universal sort of design approach that people, regardless of ability, with people with different sort of sensory disabilities could still use it, that it was easy to use and understandable by people with intellectual disabilities as well as a range of physical disabilities, and that it made sense for all of us. When we asked about implementation, the very clear response from you was that this needed to be co-designed and involve diverse communities in that co-design process. Not just, of course, Aboriginal communities and different culturally and linguistically diverse communities of course, but also diverse consumer groups and people with different diagnoses and different experiences of using health services. We needed to have a clear communication strategy, and that strategy clearly defined the benefits, risks, and outcomes to different groups of consumers, and that consumers were involved in the co-design of the evaluation, and that there were built-in feedback loops for consumers and communities to see how things were being implemented and the ongoing valuation of the record. And also people called for the active involvement of Health Consumers New South Wales as the peak and other consumer and community organisations. We asked you specifically what you thought our role as a peak should be. These are the high-level things you told us, but we had a role in brokering the relationships, not between different consumer groups and sort of forming coalitions, but also with key decision makers within the implementation authority and other aspects of New South Wales Health, to continue to advocate for sufficient resources that allows us all to be involved and engaged, and to continually monitor the effectiveness of that engagement. And ideally that we can produce toolkits and guidelines to help people in their own work if they're involved in implementation processes. And that's part of what today is, providing people with that information to show what consumers are saying. They saw that we had a role in evaluating and making sure that consumers are involved in that evaluation and in developing what outcomes should be measured. And also we have a role to ensure the participation of underrepresented group in this. There were some high-level themes that came across all the different areas when we asked people about what was important. And I'm going to go into each of these themes in a little bit more detail now. The people wanted more information, wanted more consumer involvement, obvious and not surprising concerns about privacy and security, the integration and accessibility as things are put together, linked to consumer involvement in the implementation now. It was really key that equity be included and at the core of implementation. And one of the things that came up again and again in talking to different groups was an awareness of stigma and how stigma in healthcare can be impacted by processes like this. An awareness of the limitations of the technology and what it can and can't do, and as I've already hinted at, the importance of good evaluation. So in terms of information, one of the things we found when we started to talk to people was that there's different levels of understanding about what is happening with the implementation of the SDPR. There was also a wide variety of understanding about how the current system works and what it does and doesn't do. Some people were quite surprised that this isn't already happening, that information isn't shared much more easily amongst health services, and other people were quite surprised and concerned that it is happening, at all in any context. And the current situation is sort of halfway between those two. People wanted clear and simple information that they're able to share with their networks, with members and with individual consumers and patients and carers. So the importance of having public-facing fact sheets, information on websites, things that we can share with consumers and patients is really essential. People were telling us that at the moment ambiguity is okay. We know that not all decisions have been made about this. And if there's something important that's happening but a decision hasn't been made yet, well then don't let that stop getting information out. And then that could be, a key area where we can actually help with that decision making. And more information about how consumers and consumer groups are going to be involved in making those decisions. People wanted to have a demonstration and an understanding of what the system looked like. And the suggestion has been made that we should have opportunities for demonstrations to actually see what it's going to be like to use. So both the patient portal that consumers will have access to and what will clinicians see, and clinicians be able to do and not do on the system. So we want to see a demonstration of what it's actually going to deliver and look like for users. And there was some confusion with other systems that are already in use. Um, the relationship between SDPR and My Health Record was something that came up a lot, and some misunderstandings that this will do the same thing as the My Health Record when it's actually going to be able to do a lot more. An existing data sharing program, such as the Lumos program in New South Wales, which shares de-identified patient data. There was some confusion around the role of that and the patient record, and they're delivering different things. So information to make that clear. More consumer and patient engagement was one of the other really high themes that came through. One of the key things that people were telling us. People were saying that they were disappointed that there were some consumer leaders and some really key consumer organisations that haven't had an active role in the design of the system to date, and really want to be involved in the discussions around implementation, and also in the ongoing governance and evaluation of the program. People are really keen to be involved, and we want to contribute and know that our voices have been heard and that nobody's been left out. There is a commitment from the Implementation Authority to leverage existing consumer groups and structures, both within New South Wales Health. So that might include advisory groups and consumer advisory groups that are sitting at facility or LHD or pillar level. We think that's fantastic and they should be leveraged, but also more use of existing networks and connection to consumer organisations outside of New South Wales Health, and a really strong need to strengthen those connections with external consumer organisations, and that there also needs to be a commitment to resourcing that well so that we can have the best possible engagement to create the best possible system. I'm not going to go through everything that's on this slide, but again, privacy and the importance of privacy was something that came up again and again. People wanted to know who owns the record and how can we decide how it is used. People are asking, can patients see their full record? People really want that patients and carers and people with who patients want to share it with can see the full record and not just the summary that we'll see on the patient portal. Who access the record and why? And can administrative staff access the record for any reason, or is it just clinical staff? And do we as patients and consumers have the ability to curate who sees what? And how is information that's potentially stigmatising going to be kept safe? Will we know when our record has been accessed? And how will we be informed about that? And one of the things that came through again and again was that people wanted guarantees that this was not going to be shared with any commercial interests, especially health insurance agencies. And importantly for us, what are the repercussions for any privacy breaches? What's going to happen if our records are accessed inappropriately? How are we going to be notified? We'd like to see some public reporting about that, about the number of breaches that occur and where they're occurring. And we'd also like to see some really serious consequences if people are accessing information and accessing the records when they shouldn't be. We recommend that breaches should result in reporting to the appropriate regulatory agencies. That could be APRA in the case of clinicians, the Privacy Commission for any administrative staff who access things inappropriately, right up to uh, notifying police if the access has actually been illegal. And consequences would include, we'd like to see for serious breaches would also include termination of employment. So we want some pretty robust processes around the privacy and repercussions for unauthorized access. As a subset of the privacy, there were lots of discussions about the so-called break the glass function. And so there will be some information that is stored. It's a terrible analogy, but it's going to be stored behind the glass. And that means that if people access your record as part of a sort of a routine interaction with the health system, they won't see everything that's on your record. However, in an emergency situation, that glass can be broken and the clinician or the person accessing it can see everything that's on the record. So we want some more information about who can break the glass and in what circumstances. We want to know what is behind the glass, what is routinely going to be made available and what is routinely going to be kept only to be accessed in an emergency. How are we going to be informed when the glass on our record is broken? And what's the process that happens after the glass is broken? We want a clear process that documents what happens after the glass is broken, and that there's some justification and around why that happened. We also would like to see some public transparency and public reporting on this. Obviously, not with names and whose record have been broken, but we'd like to know how often the glass is being broken on different records, what types of services are breaking the glass and comparisons. Are there certain types of services that are doing this more than others? Is it happening in different locations more than often, and why? And also reporting around the outcomes that happens after it breaks the glass. Is this actually resulting in better patient care? And those outcomes we'd like to see would include patient-reported outcomes as well. And again, as we've hinted at before, what are the repercussions of the inappropriate use for breaking the glass? And we'd like to make sure that they're robust and tough and have consumer protection at their heart. And also, when we were talking about what's behind the glass, people are telling us that, and this is no surprise, that obviously certain diagnoses people would like to keep behind the glass. That might be around mental health diagnoses. It might be around people having certain bloodborne viruses, but also it might be around the people have accessed certain services, whether that's health services in correctional settings, mental health services, alcohol and other drug services, or sexual health services. We know that people who access those services report experiencing more stigma from health services. And so we'd like to know for sure that that information is protected, and that there's even good, what are the good reasons that where people have access services is even stored on these records. Concerns about security, have been raised as part of this conversation. And people are even saying, and this is sort of a summary of what many people have said, that once data is online and is shared to the cloud, then there is always a potential risk. And of course, that's true. So people are asking, where is the data going to be stored? And it is our understanding that data will be stored on servers based in New South Wales, as it has to be under Australian law. One of the groups that's involved in the process is Amazon Web Services that Teresa Anderson mentioned that in her presentation. And we've had questions about what is the role that Amazon Web Services are playing here, and what does that mean? And again, we want there to be really clear and serious repercussions for security breaches. That if a security breach occurs and people external groups who shouldn't have access to our records do what's happening, and that there's pretty serious repercussions for that, including serious fines and potential jail terms, of course. We talked about, there were questions about the integration and accessibility of the record. What's the process by which existing services, existing records are going to be linked from different services? People have also asked about opt-out options around having all or some of their records linked, and questions about the process by which it's going to happen. Obviously, with the millions of records, individual records that are stored across the system, there's going to be some automation. What's the use of processes like AI in this linking, and how's that all going to come together? Questions about the secondary use of data. Once we've got all that information that's linked, and primarily for use in our own healthcare management, that's a very rich source of data around trends in the health system that can be used for system improvement and for third-party research. So what are the plans for using the SDPR for secondary use, for system improvement work and research? And how can people who don't want their information used in that way opt out of the secondary use of data? Those are things that people are telling us they want to know more about. So in terms of the implementation, what has been learned and what are we learning from other sort of similar processes? What have we learned from the introduction of My Health Record, and how is that informing the development of what's happening here? Also, the introduction of similar work in other jurisdictions, whether it's other Australian states and territories or what's happening internationally. We've been able to source, and some of our consumer organisations have shared evaluations around the introduction of similar processes in different countries. And it feels like it's a bit of a mixed bag in terms of what it's ultimately been able to achieve. And so how have those lessons been integrated into what's happening here and now in New South Wales? What's the resources and support and that's being used to bring all of this together, and the engagement of clinicians and staff in this process? One of the things that people have raised is, with the number of groups, the 50 plus committees and councils that are working to make single digital patient record happen in this time frame. Some of that, of course, some of those staff are, of course, across different agencies with New South Wales Health. What does that mean for the implementation of other processes? What's the opportunity costs that we're experiencing around bringing all this together now with people focusing on this? So we'd like to have a bit of an understanding of the impact of the implementation as well. And what's the resources and the planning around consumer education around the use of the record, and how we can be involved in that implementation? A real focus on equity is something that, again, is coming through very strongly. How are different priority populations and populations of people who have experienced marginalisation or stigma from health services being included in this process? And links to groups outside of health. I don't just mean consumer organisations. Some groups like groups that are involved with some of the justice communities, community organisations, sort of local groups that bring together specific populations. How are they being brought into these discussions? And again, that really clear focus on stigma that I'm going to return to in a second. Border issues. What does this mean for people who who live in New South Wales or receive healthcare outside of New South Wales or vice versa? We know that there's a lot of people in southern New South Wales who travel either to the ACT or to Victoria to receive healthcare and specialist healthcare. What's that mean for the sharing of their information for people in border communities along the Queensland and Victoria borders? What's happening there to make sure that they get the benefits of this information sharing as well? Some of the consumer organisations from the rare disease groups and the genetic conditions have been excited by the capacity or the potential that SDPR could also hold genetic information, which is potentially game changing for those groups, but also concerns about what does this mean for priority populations where such information has sometimes been used to increase stigma and to pathologise and reinforce stereotypes about those groups. So how's that being balanced? And of course, making sure that genetic information, is available to help with clinical care and not being shared with insurance and other agencies. So the question of evaluation has been mentioned as a few times, but specifically people are saying, and consumers and consumer organisations are saying, that we want to be involved in the evaluation processes, both in the design of the evaluation and in setting the questions, and in actually consumers and consumer organisations actually setting the questions about what does good look like, what are we measuring when we say we want to achieve certain things, and if we achieve the principles that SDPR was set up to do. We've heard from many of our organisations that they feel Health Consumers New South Wales at the peak has a key role to play here, but that we should also be making sure that key consumer organisation and consumer representatives and consumer leaders at both local and state levels are involved in the design and development and the running of evaluation processes. We call for transparency in evaluation, and that what we learn from the evaluation and the effectiveness of SDPR is made available and made publicly available. And what have we learned from other systems that have been introduced and learned from the evaluations, of those existing systems. And of course, after the implementation, we want to know that we've built in adaptability and feedback loops so that ongoing evaluation does lead to system improvements and where we can easily make changes where necessary. Stigma is one of the themes that has been running through the evaluation through the feedback that we've received. And there has been concerns that making it easier to share information about people's diagnoses and where they received services could have the effect of increasing people's experiences of stigma in healthcare. There's concern that could lead to some people being disinclined to use certain services and to stop using certain services that they believe are safe and anonymous. Some services at the moment, some outreach services, some sexual health clinics, allow for people to use the service anonymously. And will SDPR still have the ability to do that? And that anonymous usage actually means that uh, that certain populations trust and are happy to use those specialist services. So we want to know that that's still available and that nothing that we do here erodes the trust for those really key services. And as we've said before, that diagnoses and service types where people receive services that we know when they're shared reduce people's likelihood of experiencing stigma, that people are able to curate that, say what is and isn't able to be shared, and that there's a lot of real thinking and planning about that. So while there are these concerns, one of the other points that was raised recently that we think is worth considering is, in all of this, could the SDPR actually be a tool that will help measure the extent, impact and cost of stigma to the system? SDPR, even if it's implemented in the most sensitive way, won't unfortunately eliminate people's experience of stigma. So could it be used as a tool to start to measure the impact of stigma in the system, which I think is quite an interesting idea and something we'll certainly be advocating for. And one of the things that's also been recommended and something that we will take up and advocate for is that the reduction of stigma should be included as one of the SDPR's high-level principles and aims, so that when decisions are made, and there's sort of hard decisions to be made, that reflecting on, will this increase or decrease stigma, should be something that's front of mind. Consumers and consumer groups were very aware that the introduction of a process like this is not going to solve all the challenges that the health system faces. Some people were concerned that in some of the conversations they've had, there's been a feeling that this new process, this new sharing of health records, is going to solve a lot of the systemic issues in the health system. And while it will solve some, people and consumers were really clear to say that it won't fix other systemic and cultural issues, and that, you know, more work and the continuing work that's being done in that area, still needs to be focused on. And we need to be very clear in the communication that we tell the health system and we hear back from the health system about what we think the SDPR can and can't achieve. So the other things around the limits of the technology, is being clear about the SDPR's technical deliverables, as I said, what it can and can't do. Also, its accuracy. We hear from a lot of people that they're concerned that existing health records are not accurate. So just bringing them all together is not going to achieve accuracy. How can we have processes in place where we can monitor and correct inaccuracies in our record? As we said before, what's the use of AI in ensuring accuracy? And also, we know AI is going to be used and it has a role here, but what's being used to make sure that there's a control of the bias that we know, is often inadvertently built in to a lot of AI processes. So a lot of questions around the use and the limitations of the technology that's planning to be used here. So as I said, so that's been a really high-level summary of what people have told us, and there's a lot more information underneath each of those dot points that we will build in to the final, more detailed report that we release early February. So here are some of the high-level recommendations, again, that are pulled out of the discussion today. These are based on recommendations that people and consumer organisations have made to us. And as I said, we're going to bring this together, plus some more, plus some of our own, in that final report. To summarise all of these recommendations, what we want to do at Health Consumers New South Wales is really see a commitment to some what we believe are really important principles of healthcare. First, the concept of a commitment to do no harm, to non-malfeasance. And so we want to see that reduction of stigma and other aspects that have the potential to cause harm are eliminated from SDPR and its implementation and use. And then ultimately, this is something that is to the benefit of patients, carers, and people of New South Wales. The other high-level principle we want to see here is also the principle around informed consent, that people know how their information about them is being used, that if possible, people have the option of opting out, or if not opting out completely, at least curating what is and isn't shared and in what circumstances. Other high-level principle, of course, is good consumer and community involvement. And again, one of our high-level themes. And what we also hope is that the introduction with a principle that SDPR can actually lead to not just better consumer-centred care or person-centred care, but actually be the start of more consumer-directed care in New South Wales. And again, high-level principles of accountability and transparency, the repercussions for breaches of privacy, breaches of security, transparency about when they happen, and also transparency around evaluation and implementation are the high-level principles that come out of these recommendations. So I'm not going to read through all those. That's been up on the screen long enough. I'm sure people have had a look at that. This is the second half of those recommendations. Again, that's just bringing together things that we've already mentioned in that quick fly through today. As I said, based on those high level themes that and high level values from we believe are so important here. So what are the next steps here for Health Consumers New South Wales, around the implementation of SDPR? Well, this webinar today is part of an ongoing process of keeping you, our members, informed about what's happening and facilitating connections and conversations with other key stakeholders. So we'll be producing the final report, and we'll be sending that report out to our members, to consumers, consumer leaders, and consumer and carer organisations. We will be sharing it with the SDPR Implementation Authority, with the Minister and the Minister's Office, other key stakeholders in New South Wales Health, and it's going to be publicly available on our webinar. We've committed to a series of ongoing information and consultation throughout 2025 and beyond. And Teresa Anderson has committed the SDPR to be involved in more of those, and we'll be organising another webinar with Teresa or somebody else from the Implementation Authority early in 2025 to respond to the report and to talk about what next steps are happening. So yes, we continue to drive this discussion in our own consumer task force. task forces. We have 2 consumer task forces here at Health Consumers New South Wales. Our Consumer Leaders Task Force, which is made up of individual members, and also Consumer Organisation Task Force. And again, I know many of the people on the call today are involved in one or other of those task forces. If organisation are not members of the organisation task force, then I ask them to please reach out to us afterwards and we can share information about how you can get involved in that. We're going to continue to be part of the working group for affected communities that has been convened by ACON, and we'll continue to keep you informed about our own work and developments in SDPR through our own newsletters and updates. So thank you all very much for your time today. And before we stop, and we might have some time for some brief conversations, I do want to wish you all the compliments of the seasons and hope that you all have an opportunity to spend some time with loved ones as we approach the end of the year, and wish all of you a very, very happy new year from me and the team here at Health Consumers New South Wales. I hope there's a time for some relaxation so we can all bring our lived and living experience to the implementation of SDPR and other work in the new year. So thank you all very much. I know that was a bit of a marathon, and thank you so much for your time today. Just some of we'll take the questions that have been included that people have put in today, and we'll be implementing that into the our final report. And as I said, I'm sorry we don't have all the answers to all the questions, but we'll find out what we've got and report it back in February. I'm just wondering, Tara, is there anything else, anything important I might have missed, or key things from the questions?
There is a question here from David asking what other medical consumer organisations are involved in feedback to the SDPR?
Look, unfortunately, that's all a bit feels very ad hoc at the moment, and I know we've got some representatives from different consumer organisations on the line. So it's my understanding that there is some representation on a couple of those those councils and committees, but there's not consumer involvement in all of those committees. There is some informal connections between people in the implementation authority and some of those organisations, and there's work that's been done. The other big piece of work that I neglected to mention, and apologies to anyone from the Physical Disability Council, is some fabulous work that the Physical Disabilities Council's been doing about communication that health consumers would like to see added to our record about what's important for our ongoing care plans, connection to substitute decision makers, that sort of information as a sort of care passport. There's been some information about that. We believe that work could really inform what a really valuable patient portal might look like. So there is ongoing conversations with our friends at the Physical Disability Council and the Implementation Authority, but that at the moment that feels like it's not quite as formalised as any of us would hope that it is. So, David, at the moment it feels like there's good people talking to good people, but it perhaps could be a bit more formalised and systematised. All right. Well, look, thank you all very much. this has been really valuable. We will be making this recording available to our members who couldn't make it today. I want to thank you all very much for joining us and look forward to continuing this conversation in 2025. So we'll give everybody a 10-minute early mark, and thank you all very much and putting up with just an hour of me talking to the screen and hoping there's somebody out there in cyberspace listening. Thank you all very much.